This presentation is about a material which is easily and inexpensively prepared and which can be stored in a refrigerator or freezer for future need. The amniotic membrane is an extension of the skin of the developing fetus. It is entirely non-energetic when applied to a burn wound. In the course of about 50,000 applications over 13 years, there were 0 complications nor any cases of disease transmission. As a surgeon and burn care specialist, I had opportunities to compare this material to every alternate method of burn management. Once I discovered the use of amniotic membranes for burns, the results were so dramatic that I never again used any other burn covering. Pain relief was almost immediate, and healing was accelerated by at least 50%, with much reduced scar formation. In the following slides, I will show you how to prepare and store amnion and give a few illustrations of the amazing results my patients enjoyed. However, note that it is essential to view the video I have produced to accurately perform the preparation. For questions, text me at abwalker1641@gmail.com. The first step is to find an obstetrician to help obtain a clean, fresh, sterile placenta from a full-term, healthy parent. Most obstetric units have irrigating saline and betadine solution on hand. Request the obstetrician to rinse the fresh placenta under running tap water to remove as much blood as possible. Then put it in a Ziploc bag with 6 ounces of betadine, also known as generic povidone iodine, and an optional equal amount of irrigating saline. Then place in a refrigerator to be collected within 24 hours. Note that bovine or cow amnion, if available, is produced in the same way and is an excellent substitute. I will review the steps briefly in the next few slides, which you can see in detail on my video labeled Preparation of Amniotic Membranes. Note you will need a tweezers and a good pair of scissors soaked in 70% alcohol and a package of sterile gauze pads, as well as a sterile surface on which to prepare the amnion. This photo shows how the amnion is easily separated from the placenta up to the umbilical cord, where it is cut free, giving approximately 1 to 2 square feet of membrane. Clean, non-sterile latex gloves rinsed with 70% alcohol are adequate for the preparation. The next steps are performed to ensure that all viruses and bacteria are completely eliminated before placing the amnion in storage vials for use. A series of 6 basins are prepared with 100 cc's of sterile irrigating saline, purchased or made with 1 teaspoon of salt in a quart of boiling water. The first basin gets 1 ounce povidone iodine solution. The next basin gets 1/2 cc of household Clorox. The last basin gets 500,000 units of injectable saline. Bottles of 1 million and 5 million penicillin units are inexpensive and readily available. They may be obtained by the obstetrician or from a veterinarian source. Then rinse the intact membrane in betadine for 1 minute and in Clorox for 1 minute. Then in the next 3 saline basins, and finally place the remaining membrane in the basin with penicillin. Use a 10 cc syringe to draw up the saline penicillin solution and place 2 cc's in each of 5 to 10 plastic 5 cc plastic vials with caps available online or from the hospital. Then use a prepared plastic surface. A dog training pad face down works well, cleaned with 70% alcohol and allowed to dry. Place the amnion with the mucus side up on the surface and scrub clean with several gauze pads. Finally, cut into approximately 6-inch squares for use, and use the tweezers to place each piece in a vial of saline penicillin. Cap and store in a refrigerator for up to 6 weeks, or, which is almost as good, place in the freezer for up to 6 months. This slide shows what amnion looks like under the microscope. It is a single-celled membrane which has the ability to form a very tight attachment to living tissue, that is, in this case, the burn wound, eliminating bacteria and encouraging the rapid growth of repair cells to grow replacement skin. Because it has to separate the maternal and fetal immune systems, it has developed proteins which make it invisible to the immune system. This first case is a young man who backed into a shelf with a tureen of fresh hot coffee. He was in extreme pain with a 12% superficial second-degree burn. With normal burn care, he would have been admitted to the hospital and had daily painful burn dressings for about 1 week. In this case, amniotic membranes were placed with an occlusive, bulky outer dressing, and he was discharged from the emergency room on no pain medication to return to work the next day. He was redressed at 24 and 72 hours as an outpatient. The amnion here is still attached to the burn wound, so there is no pain associated with the redressing. Here is another superficial scald burn from hot coffee. It is approximately 15% body surface area, which is considered a major burn in this age group. Because of her age, brief anesthesia was used for cleaning the burn and applying amnion. Once the bulky dressing was applied, the awake patient showed no more signs of pain. Because the burn wound was completely isolated by the amnion and the dressing, no isolation was necessary on the ward, and the mother could hold the patient for feeding. She eagerly accepted fluids, and IV was discontinued the next day. She was discharged at 48 hours for every 2-day outpatient redress. As is obvious, the exposed burn wound is isolated from the environment by the amnion, so the exposed nerve cells do not fire any pain impulses. The patient is completely pain-free, and healing was complete at 3 weeks with no residual scar. This older patient pulled a pot of hot water from the stove, receiving a somewhat larger and deeper burn. After the amnion and dressing was applied, he was completely pain-free in the recovery room. Only about 50% of the standard IV rehydration was necessary because the amnion rapidly sealed all the leaking open tissue. The patient was able to freely ambulate around the room with his bulky dressing until discharge at 4 days. When changing the dressing, slightly deeper burn areas may appear wet and will need additional amnion applied. As the burn finishes healing, the dry amnion flakes off. Note that because the sealed burn is painless, the patient has no anxiety and is very cooperative for the redressing. Standard current burn management requires daily burn redressing with general anesthesia. Note this patient had no visible scar at 6 months. These 2 patients had similar second-degree burns. This is the typical bulky dressing which allows full activity and outpatient care. They have just been redressed, and they clearly have not had a traumatic experience. Their nutrition is excellent in spite of the fairly large burns because of the lack of pain. This unfortunate child was in a house fire and had extensive third-degree burns on her face and scalp. She required skin grafts and prolonged daily dressings, but remained cheerful and well-nourished with no supplementation throughout her recovery. Note that even third-degree burns are painless for redressing because the amnion isolates the sensitive nerve endings from air. This greatly reduces the morbidity and expense of repeated anesthesias. This preteen was working on a car with his uncle, and the carburetor backfired in his face. The burns appeared to be deep second and third degree. After initial debridement with anesthesia, an amnion mask was applied. After the third debridement, the amnion began to stick, and further dressings were done with the patient awake. The healing proceeded remarkably quickly over 2 weeks, and there was minimum residual scarring. This is a similar patient after a rocket fired unexpectedly in his face. Here the amnion is shown as it slowly peels off when the burn has healed underneath. This patient was an abuse victim, put in a tub with near boiling water, and forced to stand, then sit for an extended time. He required intensive care and multiple debridements with anesthesia. All of his burns were redressed daily at first with fresh amnion until it began to stick. 80% of the burns were secure and dry, like the last cases, within 1 week. He was nearly pain-free and had no trouble with awake dressing after that period. Note the amnion was particularly helpful around the perineum and buttock areas because it seals the wound from contamination. This is a close-up of his more severe burns on his feet. Surprisingly, only a relatively small portion on the top of the feet required grafting because the amnion dressings kept the wound sterile and encouraged rapid epithelial growth as the wound was debrided. To see how amnion results in third-degree wound healing, watch my separate presentation, Amnion Use in Full-Thickness Skin Injuries. Here he is 1 year later, final healing with very little visible scar and no limitation of his joints when walking. This result represents a very nice result from a very severe burn that could only be obtained with the use of amniotic membranes. This patient was referred from a small burn center after getting third-degree injuries to both legs when gasoline splashed on her pants and caught fire. She had been in the operating room at the other hospital for debridement and grafting approximately 30 times over 3 months and had been limited to bed because of severe pain. She had been unable to eat properly and had been sustained with elemental diet through a tube. She had chronic Pseudomonas infections over both legs. The wounds were debrided with anesthesia at this hospital, cleaned with betadine, and amnion applied under an antibiotic dressing. The next day, she felt pain-free and was able to get out of bed and walk for the first time in 3 months. After 1 week, all the amnion was dry and adherent. The worst areas were where multiple grafts had been taken and had become infected with Pseudomonas. Note that experiments with animals given fatal Pseudomonas infections to open wounds show that the wounds dressed with amnion become sterile in 72 hours as the amnion becomes fastened to the wound surface. For more literature review, read my chapter Use of Amnion Membranes for Bone Wound Coverage. At this point, the patient was ready for discharge with closed dressings and follow-up outpatient care. Here you see final healing at 4 weeks and 1 year with very little visible scar and no limitation with walking. This result represents how the Amnion can solve very serious, complicated, infected burn wounds. In dealing with children, it is important to minimize donor areas when doing skin grafting. A special machine allows the graft to be expanded up to 400%, but then this material is very difficult to work with and secure in place. By spreading the graft on Amnion with a gauze backing, this whole process is much faster and more accurate, and no sutures are needed and later have to be removed because the Amnion holds everything securely. This photograph illustrates the graft in place with the Amnion dressing temporarily removed. A wide mesh like this may take 3 weeks or more to heal with standard care. The Amnion, however, speeds epithelialization across the gaps as well as over the donor site, so there is less scarring and pain and much more rapid recovery. This photograph shows the amniotic membrane being replaced on the burn wound prior to bulky protective dressing being applied. This wound was healed at 1 week. Eventual scarring was very mild, and there was no limitation of function of the joint. This final example is a patient with a rare condition in which the epithelium peels off with every slight shearing pressure. All reported cases become crippled by scar contractures, and most die by 12 years of age. This patient was treated at a major children's hospital for 3 months and had become unable to swallow, had chronic infected wounds over 30% of his body. He was referred to the Amnion Clinic as a last hope for his survival. This picture is after only 3 weeks of care with every 2-day Amnion dressings and whole-body protective dressings. He was able to return to full oral feeds at this point, and the gastrostomy tube was removed. He was discharged to outpatient care after his mother was trained in maintaining his protective dressings. At 6 months of age, he has only occasional blisters which heal within 48 hours after the Amnion application. This very attentive mother was sent home with dressings and prepared pieces of Amnion to manage his care between 1 to 2 week visits after mild injuries. And finally, here he is defying all expectations at 7 years. Except for the bulky dressings on his arms and legs, when he goes to school, he leads a normal life. This presents a unique case in which a universally grim disease can be transformed into a normal childhood growth because of the availability of Amnion. Here is a review of the reasons why Amnion is the ideal burn dressing. 1, it is easy and inexpensive to produce. 2, it can be safely stored in normal refrigeration or frozen. This Amnion is proven to be very safe and non-antigenic. The Amnion is easily applied with very little training. The Amnion effectively seals and sterilizes the wound. It significantly reduces pain during dressing changes compared to all other dressings, and it significantly reduces the healing time and the amount of scar formation. Here are some additional special considerations when using Amnion. For safety, amniotic membranes must be prepared and stored following the directions in the video exactly. Incidentally, Amnion has a distinctive, musty odor, which is normal. If at any time this odor changes or the appearance of the amnion seems abnormal, it should be discarded. Amnion may be kept in antibiotic saline in the refrigerator for up to 6 weeks, or may be frozen for up to 6 months. Amnion must be handled and applied in a clean environment using sterile gloves, containers, and sterile surfaces. When applying Amnion to a wound, the exact dressing materials must be available and used following the video directions. I will have a future presentation on the actual application of Amnion to a burn wound. Amnion must be applied within 48 hours of injury and checked every 48 hours until it becomes dry and fully adherent. Here are some other considerations for anyone interested in starting an amnion bank. Unfortunately, the use of amniotic membranes was terminated after the AIDS crisis because of litigious climate concerns. Note it is a trivial exercise to prove that no viruses nor bacteria survive after bathing in iodophor and Clorox solutions. However, no major companies nor burn establishments are willing to work on producing amnion safely, partially for financial reasons, since it is very inexpensive to produce, and partially because no living person has the intimate experience and documentation that I have with this product. For more information, refer to my Amnion chapter footnotes for other experiences from the 1960s and 1970s. I have the patient records of approximately 1,000 patients and 50,000 plus Amnion applications over 13 years of managing an Amnion bank. Also note, bovine Amnion is a viable alternative. I have used it with identical effects. It is available in large quantities from slaughter factories that produce fetal calf serum. However, it needs to be proven that bovine spongiform encephalitis is not an issue.